Okay, I'm going to start the recording. All right. Welcome everyone to our retraining for the Lyme meningitis study. We are excited to recap the study and outline the changes made and lessons learned from our first year. We have enrolled 14 patients so far and look forward to many more this upcoming Lyme season, now that all sites are activated. Next slide. Please make sure to click on the link in the chat box so we can capture everyone's attendance on this call. I'm going to put it in again for those who are on after I posted it. Okay, next slide. I'm going to walk through the agenda. First, Dr. Elise Negrovic, the lead PI for this study, will give an overview and summary of Lyme tests. After that, Dr. Tom Chen will walk us through a few eligibility scenarios to test your knowledge of this study. We will then hear from the Boston research coordinators, Rachel Oresco and Maxwell Baker, who will walk us through the study workflow. After that, I will go through reminders, a good clinical practice refresher, and provide study updates. Then Bethany Fuller, a data manager at the Data Coordinating Center, will present a REDCap refresher, and we will wrap up with final business. I also want to thank our admin assistant, Audrey Connor, for advancing the slides today. Next slide, okay.
All right, I think I'm up first. Thank you, Anna.
Receive a handoff, please. Survey, please.
All right, so we wanted to just very briefly remind you why we're doing this study. So go ahead to the next slide. Probably the most definitive source on treatment and diagnosis for Lyme disease is the IDSA guideline, which was released in 2006 and then updated 14 years later in 2020. Next slide. And so the PICO, that is the clinical question that we're really trying to contribute to, is what are the preferred antibiotic regimens for the treatment of acute neurologic manifestations of Lyme disease without parenchymal involvement? That's what we're talking about, Lyme meningitis. And so the guideline in 2020 changed to say that either intravenous ceftriaxone and cefotaxime or oral doxycycline are appropriate first-line agents. Pen-G is listed as well, although it's just not clinically used, partly because of the dosing interval, et cetera. And so our goal is to really, that decision was made on limited evidence, particularly limited evidence in children. And so we're trying to make sure that that's safe as practice changes very dramatically. Go ahead, next slide. So our goals for AIMS 1 and 2 are to compare doxy to intravenous ceftriaxone and cefotaxime for the treatment of Lyme meningitis. And AIM 1 is short-term recovery, that is 30 days or how long it takes for symptoms to resolve. And AIM 2 is long-term quality of life, which we define as 6 months after enrollment. And then our last aim, which is the qualitative aim, which is to really look at patient, parent, and clinician preferences in order to better inform shared decision-making, particularly if we don't see an efficacy difference. Next slide. So we now have 21 centers in our group, which we're really excited about, with pretty good geographic range. Obviously, 9 of them are in New England, 9 are in the Mid-Atlantic region, 3 are in the Midwest.
Yeah.
Our overall goal, when we can say we're done, is when we enroll 250 patients, and we'll keep coming back to that. We've only enrolled 14, so that's 236 more to go, but we'll talk about goals per site, and we're targeting or hoping that sites can enroll at least 4 per season. And there's no upper limit, but some of the high volume sites, we hope to enroll 10 or more. Next slide. Just a few announcements. Fran Balmuth, who was the site PI at CHOP, is transitioning her role there in the study to Rebecca Green, who's a fabulous new attending there with her adorable baby. So that's one announcement. And then next slide. We were able to recruit the University of Vermont group, adding another state to our geographic range. They're an area of emerging Lyme disease incidence, and a lot of their patients come actually across the border from New York. So we were glad to be able to recruit them. Christian Polcini, who's a K-funded investigator there, will be the site PI, and we're working closely with them to bring them on board. They're not quite onboarded, but they're making great progress for anyone who's on the call today. Next slide. Okay, what are our outcomes? The primary outcome is the symptom score, which we call the Lyme meningitis symptom score, and it includes severity of headache, neck pain, presence or absence of fever, sensitivity to light, and problems with their vision. And that's the primary outcome for AIM-1. AIM-2 is a PEDS QL score administered at 6 months. And then for AIM-3, we have qualitative interviews. And it's not part of our training today, but Sarah Vargas from Rhode Island Hospital is interviewing these patients and her team at 6 weeks and really getting some great qualitative information. So that's going to add a lot to our study. Next slide. Okay, who can we enroll? This is a key part of the training. We'll come back to this later with our quizzes that Tom's going to give. So we're looking at kids 1 to 21 years of age, a broad definition of children who have meningitis by an LP or whose clinician says they have meningitis and that they have positive 2-tier serology for Lyme disease. There are a few exclusion criteria. That is, you're not planning to treat the patient with either of the antibiotics we're studying. We don't want to include those patients. So if they're going to do amoxicillin or azithromycin, that's not a patient we want to enroll. We need to enroll the patients before they receive 7 days of antibiotics. Also, we don't want to include patients who can't report their symptoms. So a nonverbal autistic kid would probably be a challenging patient to enroll because we wouldn't know when their symptoms improved. And we have all the study activities now approved in English or Spanish, and we'll come back to that with the IRB issues. And also, if you know that they have bacterial meningitis at the time of enrollment, that's an exclusion criteria. So that's a reminder. Those are the key elements of the inclusion-exclusion criteria. Next slide. I want to do a quick reminder about Lyme tests because these actually can be quite confusing. We're here for questions, but just wanted to remind the team who will be screening these Lyme tests. So we are only enrolling patients who have Lyme disease, Lyme meningitis, and we will take standard 2-tier tests or modified 2-tier tests. And I'll go into what those are. Currently, about 3/4, 2/3 of our sites are still using standard 2-tier tests, and about 1/3 to 1/4 are starting to use the modified 2-tier test. And I think as we look at this each year, there'll be more and more that are using the modified 2-tier tests because they're a lot easier to operationalize. So standard 2-tier test is an ELISA test, followed by, if that's positive or equivocal, an immunoblot test, which has both an IgG and an IgM component. And you need to have both the first and the second tier test to be positive. Positive IgM counts only if you have less than 30 days of symptoms. A modified 2-tier test is 2 orthogonal ELISA tests. So no a blot, just 2 ELISA tests. And there's a couple different testing algorithms that are currently approved to be used in this way. So if you have a positive or equivocal first tier test, then your lab will reflex to the second tier test. And if that's positive or equivocal, you can consider the patient have Lyme disease. Next slide. We have some examples that show how this might look in the medical record for those that are screening. I think we have an example from Boston Children's, which is what we have here, which we use a standard 2-tier test. And we have a Cerner medical system currently. So just in terms of the way things look on the screen. So this is a Boston patient, de-identified, but their first tier test, the result is 3.74. It's in red, so you're clued into it being abnormal, but you can look here to the key. And so it's greater than it's in the positive range as per the text that comes. So then that patient would reflex to a second tier test. Next slide. And for standard 2-tier, that's the immunoblot. So, or Western blot. And our lab here says that both the IgG and the IgM are positive. Next slide. But those tests are not just positive. They have actually bands that are included. And so we will have you upload the exact report. This patient has 10 out of the 10 possible IgG bands, which is in this large, hard to read free text report. And 2 out of the 3 possible IgM bands. So is positive for both IgG and IgM. So that report would be uploaded, and we'll talk a little bit about that. Next slide. So this is a patient also from Boston who has a equivocal first tier test. So it's in that range between 1 and 1.20. And so that would also reflect to a second tier immunoblast. Next slide. And you can see here that both, although the first tier test is equivocal, that the second tier test is negative. And so this patient would not be eligible for the study. Next slide. When you want to look at the specific bands, they have less than the 5 required bands for IgG and less than the 2 required bands for IgM to be positive. Next slide. So this is a patient that was shared from CHOP, and they're using a modified 2-tier algorithm, and their EHR record system is EPIC, so it's going to look a little different and be more familiar to those who are used to an EPIC result. So here's a de-identified patient, and the first tier test is an ELISA test, and so it's in red, 3.93, and so you look at their reference range, and that's positive. So that's going to reflect to a second tier test. Next slide. And so for the second tier test, that has 2 components. And so we have an IgM ELISA second tier test, and it's 0.94. And then we have an which is equivocal, but the IgG ELISA test is 5.58, which is clearly positive. So this patient has Lyme disease and would be eligible for the study if they meet the other criteria. Next slide. So one thing we've discovered over our first year is that not every patient will be tested within your hospital system. So we will take any Lyme test as long as it's a legitimate standard 2-tier or modified 2-tier test. But if it's not done in your system, we have to get documentation of that. So sometimes that's through your electronic health record portal. Sometimes it's the parent coming with access to the result on their phone when they present for clinical care. But we need to get documentation of that so we know that they're eligible. That documentation, whether it's a picture, whether it's an EHR de-identified report, will be uploaded into REDCap. And that will be looked at by the study team, essentially me, just to make sure that all the patients we're enrolling really do have Lyme disease. So we need to see both the first and the second tier, whatever kinds of tests that are enrolled. And I'm committed to reviewing those as soon as possible, hopefully within a few days of the patient being enrolled. Does anyone have any questions about the Lyme tests? All right, we'll keep going, and maybe some of the cases will highlight something. So next slide. Tom, are you jumping in on this one? The question, part of.
Sorry, I keep.
Yeah.
Actually, I think this is a new slide.
Still me? All right, perfect.
Yeah, no, we did.
Perfect. So the question comes up, as we talk to sites about how do you find these patients? Sometimes for those of you that work in the emergency department, it's based on, the chief complaint or that brings them to the ID clinic or the emergency department. And then another thing that's been key too is that because these patients are cared for by potentially neurologists, infectious disease doctors, hospitalists, that you want to make sure that those other teams are also aware that this study is going on. What does that mean? That might mean attending a research conference, occasionally, but an annual email. In fact, we should send out a text because some text that you could share, because as we approach the Lyme season and head into early April, I'm going to remind the folks locally, and we can share the text that we're going to use for that. Another way to find these tests, and probably the more useful one, is to get some automated reports when Lyme tests are sent. And so whether it's real time, right when the test is ordered, or the next day, having an automated report that a Lyme test has been sent is very useful. And then you can screen the patients who've been tested for Lyme disease to see if they meet the other criteria. We also have an automated report to see if a lumbar puncture has been performed so that we can screen those patients as well to see if they've been clinically evaluated for Lyme disease. And those automated reports, in addition to the clinical screening in each of your environments, will help you find these patients that are potentially eligible. Next slide.
Actually, sorry, Lisa, if I
yeah.
can jump in.
Of course.
And sorry, I didn't remember the slide coming up before. Yeah, so let me just talk a little bit about what we do here, and hopefully that helps. So when our RCs are covering, they're constantly screening. We have Epic, and as Lise mentioned, we get a BPA, so best practice alert. It automatically notifies the research team anytime a Lyme test is ordered or an LP is done. So far, have we had any enrollments from outside the ED? I don't think so. But I'm still reaching out to anyone who might see them. So I send an email. I don't try not to bother them too much. To our primary care clinic, to our hospitalists, to our ID folks, to our neurologists. I know that some places have a Lyme follow-up clinic or a Lyme clinic. So just knowing what the resources in your area are, reaching out to them and just asking them to keep an eye out for them. Again, depending on how your system works, most times it's still going to be the pre-enrollment information sheet. So giving them a PDF copy, or again, whatever works for them, a paper copy. In RED, we have RCs covering for 19 hours a day. It's unlikely to happen in the middle of the night, but we have paper copies in our research area in ED, so they can just grab a sheet, give it to a person. And the way we log it is, if that happens, we ask the ED attending to secure chat me and the research team. And that way we know it was given. And it's our documentation that the sheet was given and that they agreed to contact if the test was positive. So really think about your site and what works best for you and how your system works. But there's a whole variety of ways to do this.
Thanks, Thomas. Great addition. Okay, now you're definitely up.
Yeah, that's what I thought. Okay.
Wait,
so,
Tom, can I interrupt? Okay.
Yeah.
So if you folks can...
Brenda, did you have something to add in, or are you... Okay.
Yeah, I was just going to give the instructions before Tom takes over. So I'm going to quickly explain how the survey tool works. So please scan this QR code or log in to slido.com and enter the number on the screen to get access to the survey. The first question will pop up as scenario 1, and you can provide a yes or no after Tom has read the scenario. We'll give everyone a few minutes to answer, and then you will see the results on your phone as soon as I close the survey question, and then we will go to the next question, and it should automatically pop up on your phone. So I have included, or computer, whatever you're using, I have included this QR code on each slide, but you should only need to scan it once, and the questions will automatically populate to the next one. All right, Tom, take it away.
Okay. I'm hoping everyone's had a chance. Yeah, there you go. Then the QR code's there. So let's jump right into the first scenario. So you have a 10-year-old female who's referred by their PCP, who's had 10 days of headaches. It's worse with her moving her head or neck and diffuse myalgias. She doesn't have any fever or stiffness, neck stiffness per se. No rashes, no other symptoms. The PCP ordered a modified 2-tier test. So that's 2 ELISAs. Through an outside lab, and today the results came back. The first EIA was equivocal, and the second EIA was positive, and they send them to the ED looking for a second opinion. In the ED, she's non-toxic, she's afebrile, her vital signs are stable, her physical exam matches what was described. You do think she has Lyme meningitis, and you plan to discharge her with oral doxycycline. So is this patient eligible? We'll give you a few seconds to enter and answer. I'll let Britta make the call on when to advance.
All right, so We had, oh, I moved it forward before I saw how many the results were. Let's see. Okay, 96% were yes, 4% were no.
Okay, so the answer is yes. She meets all inclusion criteria and not any exclusion. One small catch, and yes is still the correct answer. You do need to confirm that the two-tier test was positive. So you need documentation. That's one of the requirements, is that there is documentation of the positive test. And that can be any form. So the PCP could fax it to you. If you have access to the labs, that'd be great. If the patient has, or the parent has a copy of the lab result or screenshot, whatever, or takes a picture of it and sends it to you, that's totally fine. But you do need some kind of source documentation. You'll hear that word a lot, source documentation. This is it. There has to be some physical proof of the lab result, not just a verbal report. And it's just a reminder, and Lee's just covered it, that the testing does not have to be at your lab. It can be at any lab as long as it is either a standard two-tier or modified two-tier test. I don't want to put anyone on the spot. Since there were 4%, it was great that most people got it right, but just curious if someone wants to put in the chat or speak up on what tripped them up on why they might have said no.
Tom, you do have a question in the
Oh
chat.
yeah. So Lise, I don't know if you want to. It's not really a scenario, but it's related to the inclusion and exclusion.
Yeah, so that's a great question. We chose to not include, I'm going to give you the long answer, infants in the first year of life, partly because it's very unusual to get Lyme disease, and there might be some overlap with congenital infection, or at least some questions about that. But we did decide to include kids 1 and up, and we understand kids 1 to 2 are variably verbal. And so some of the Lyme symptom meningitis score might be hard to assess. We're going to ask the family, the parent, to sort of report their symptoms to see and trend that over time to see if they're getting better. And we understand the challenges of a parent reporting whether their 1.5-year-old has a headache or not. And I don't think we'll get many enrollments in that age group, just having studied Lyme meningitis. It doesn't happen very often, but we didn't want to exclude too many on the bottom end, just in case there's any differences in how they're treated or whether they're time to get better. So, in the pre-verbal kid, we're going to ask the parent, who's going to be filling out the text survey, to make their best guess about those symptoms. The objective symptoms like fever, are clear and easy to do, but they're going to have a little bit of subjectivity in that.
We did have one last fall that was 3, and it was an unusual case. The parent was pretty clear. The constellation of symptoms were pretty interesting and unusual too. I'm trying to maintain patient confidentiality here. But the parent did. You're right. I mean, a 3-year-old, how reliably do they talk about headache and things like that? The parent, for what it's worth, the parent felt very comfortable that my child is not normal. I think their head hurts. And there were just other factors in the case that really said, yeah, this sure, the two-tier test was positive. I mean, we thought this sounds like Lyme. And so it was, it's a great question because it's not easy. And I think the bottom line is we rely very heavily on the parents because they know their kids. They know their kids, and they know what their symptoms are. And at least in that one scenario, it was not as great as you might think it would be. I mean, the parent was pretty clear about what they thought the kid's symptoms were. I don't know. I'm not sure who DEID is. Did we answer your question or any other thoughts? And thank you. And did anyone want to comment on it, particularly if this the folks who answered no on this question? Any other questions? I'm not trying to put anyone on the spot. Okay, let's go to the next scenario then. So in this scenario, we have an 8-year-old male who was hospitalized 2 days ago with fever and headache and looked very ill. So ill they did an LP and Lyme serologies. The CSF revealed no white blood cells per high powered field. The gram stain was negative, and the glucose was normal with a mildly elevated protein. They were concerned about this young man, so they admitted him, treated him with IV ceftriaxone. On day 2, his CSF cultures were negative. His first tier Lyme EIA was equivocal, and his second tier was positive. His treating clinicians are planning to treat him for Lyme meningitis with IV cefotaxime through a PICC line, peripherally inserted central catheter. And so is this patient eligible?
We'll wait for just another 30 seconds. We don't have quite as many results yet. Okay, I think we have about the same as last time. So we have 40% yes and 60% no.
Okay, so that's great. We're glad. And I think we can make a guess on what tripped up many of you. But we'd really love to hear from folks who said no. So yes, this patient does meet inclusion criteria and doesn't meet exclusion. And I'm guessing that what tripped up a lot of you is that in the previous training, we said that the CSF cell count had to be, if they had an LP, the CSF cell count had to be greater than 10 whites per high powered field. And this is no longer an inclusion criteria. And this was based on feedback from a couple of sites who had kids just like this, who had negative LPs. And they said, but positive Lyme tests. And they said, we really think these kids have Lyme meningitis. We know they don't have a pleocytosis. They don't have white cells in their CSF, but we really think they have Lyme meningitis. And in taking that feedback and talking with the expert panel that we have, we decided that should no longer be a positive LP is no longer a criteria. It really is the clinical judgment. And I'm going to stop here and actually ask Lise to comment a little more on that.
Sure. So this is a real world study. We're observing what clinicians do in practice. And so we want to at the same time, we want to capture the breadth of what Lyme meningitis will look like. So some children with Lyme meningitis clearly will have a pleocytosis, but if they have signs and symptoms that make the clinical team diagnose meningitis, so headache, stiff necks, sensitivity to light, other things like that, then we want to include them. And we're going to study them because this is the real world and this is what happens. So we're inclusive in our definition for that regard. And there were a couple specific cases that Nationwide and Stony Brook brought back to us that showed where this did happen. And so we talked with Sunil, who's ID Lyme expert from Cohen Children's, and had a nice conversation. We decided to broaden our inclusion criteria.
The other thing I'll mention, I'm not sure if this tripped up anyone, was the cefotaxime. I know in our study title, we talk about doxy and ceftriaxone. Cefotaxime is the one other IV antibiotic that is inclusive, and that's because clinically ceftriaxone and cefotaxime are essentially the same. And so cefotaxime is the only other antibiotic that is included in the study. It's not just doxy and ceftriaxone. If someone got tripped up on something other than those two things, and you feel comfortable, we'd love to hear from you just so that we can help clarify anything that was unclear. Yeah. Okay, let's move to the next scenario then. Last one. So this is a complicated one. This is a case that we had here in Rhode Island. And I think there was a lot of really interesting things about this. This is a 14-year-old female who had, as you can see, a very complicated set of symptoms and course. So a month before she presented to the ED, she had intermittent fevers and headaches. Her PCP was concerned, treated with amoxicillin. Her symptoms didn't improve, so they switched her to a week of amoxicillin clavulanic acid, Augmentin, and the fever and the headache did resolve. 3 days before coming to the ED, the headaches returned, but no fever. And she came to the ED because of acute loss of vision in one eye. She gets an LP that you can see is positive. She has 22 whites per high-powered field. The diff and the gram stain were normal. She gets an MRI and an ophthalmology consult, and they diagnose optic neuritis. A Lyme standard 2-tier test is sent, and she's admitted for IV steroids. By her second hospital day, her vision is much improved. The headache persists though, but she's good enough to be discharged. And the following day after discharge, her standard 2-tier test becomes positive. She, when they were contacted, mom said that she's still having headache. Our team reached out to the treating team, which is again one of the twists. So inpatient, she was hospitalist. Outpatient was going to be and this was the plan even at the time of discharge. The follow-up was going to be with the infectious disease clinic. And so it was not the ED or the hospitalist that were continuing to care for this person. So we reached out to the ID team and ran the scenario by them. And they said, yep, we have an appointment to see them in clinic. We think she has neurologic Lyme and we're going to treat with doxy. So is this participant eligible? Patient, I should say, not a participant yet.
There's a hint there, though.
Yeah.
All right, so we have 72% yes and 28% no.
Okay, so this patient is also eligible, and not quite sure what tripped folks up, but we'll go through these things here. If she had been on doxy, ceftriaxone, or cefotaxime prior to the ED visit hospitalization, she would have been excluded for that. But amox and amoxicillin clavulanic acid are not exclusionary. If you're wondering, well, doesn't it treat Lyme? Yes, it does. It doesn't cross the blood-brain barrier, and so it doesn't treat Lyme meningitis or neurologic Lyme. So that's it might be thinking, yeah, but they got treated, but in this case, not what we're interested in. Steroids is not an exclusion. She was improving, but even at the time of the positive Lyme test, she still met criteria. She still had the headache. And I think that's also, well, I don't want to speak for our ID people, but I think that's why they said, you know, we're going to treat her for doxy. And the treatment team decision, it wasn't included in the slide. She was actually going to be seen and started after 7 days of the Lyme test is when the appointment was, but the decision to treat was made within the 7 weeks and 7 day window. And so she was eligible for all those reasons. It was a tricky case, and for me, there was a little bit of, and I reached out to Lee's and I laid this whole thing. I was like, but the treatment's going to start 7 days later than 7 days. And so I had to double check myself and said, no. The treating team feels she has Lyme meningitis and they have said, we had it in writing, we are going to treat her for Lyme meningitis with initially they said 2 weeks of doxy when they saw her. They looked bad. She looked bad and they said, okay, we're treating her 3 weeks. That's all another discussion. I don't know if Lise wants to go there. Yeah, there were a lot of subtleties and a lot of nuances to this case. And so really want to, and I'll take my stab at Marlene's question, Lise, but I'm curious to hear yours. Lyme and the brain, it can be lots of different things. And so Lyme meningitis, when you have obvious headache, fever, light sensitivity, stiff neck, I mean, that's an easy one. That's what you have. But it can present in other ways. And we've actually, even in the kids we've seen many who don't have clear meningitis, but do have headache and do have other neurologic symptoms. The Bell's palsy, as a lot of you know, and you guys will probably see a lot of Bell's palsy who won't qualify because that's the only thing they have is Bell's palsy, a positive Lyme test, but they don't have headache and they don't have other symptoms. And so because the thinking there, by the way, related is that in those cases, probably very isolated. It's probably literally isolated just to that facial nerve, and it's not really involving the whole brain. Whereas these other cases, and that's why we brought in the description, is that Lyme can be with headache, Lyme can have frank meningitis, Lyme can have other neurologic symptoms where we think it's more diffusely affecting the brain. And so, no, strictly speaking, it's not the same because Lyme can affect in multiple ways, but we're trying to capture both. And I don't know if I said that correctly, Lee, so I will turn it over to you.
Sure. No, that's great. Just to echo what Tom said, there's many neurologic manifestations of Lyme disease, Bell's palsy, brain things. We're trying to get at those patients who meet our clinical definition for Lyme meningitis. Katie, you ask a really interesting question, and I think so this is an unusual case. And, people might think, well, maybe it's Lyme meningitis, but maybe it's an autoimmune encephalitis or other things, and the Lyme titers are just incidental. We are really hinging on the decision of eligibility for this type of unusual case on the treating clinician's plan. So if they really think it's an autoimmune encephalitis and the Lyme titers are positive because the child had Lyme a year before, and they don't think there's current Lyme meningitis, even if they might do, doxy just in case, then they wouldn't be eligible. In the case that Tom so nicely described, the clinical team who knew her and were making treatment decisions knew that it was an unusual case, but felt like she had acute, I don't even know if it's a she or he, but acute Lyme meningitis. So this is tricky. We want to be inclusive, but we want to, make sure the patients have the disease that we're looking at. The good news about this for people that are used to ER studies where we have to enroll like this moment, a lot of our enrollments are going to be happening after the fact. Tom and I are essentially always available to discuss cases. And so when it's confusing like this, I'm happy to have a conversation about whether they meet the eligibility criteria or not. But we chose this case as an example because it's unusual. And I would not be surprised if this patient comes back and has other long-term things than just Lyme meningitis. But it's still an important patient to include as we look at this broad spectrum of diseases.
And for the really geeky, nerdy people out there, and Katie, is a great question, and I didn't include it. This kiddo was MOG, myelin oligodendrocyte glycoprotein positive. And to your point, to your question, when I talked to both ID and ophthalmology, they both said, yeah, is this some autoimmune thing? And with her being MOG positive. But in the end, it's exactly what Lee said, that the treating team said, well, it may or may not be, but we still have to consider the possibility, and we're still concerned that she might have Lyme meningitis, and if we don't treat her, et cetera, et cetera, et cetera. And so it was their call. They called it and said, yes, there might be alternatives, but we think we have to treat this patient like they have Lyme meningitis, and they did.
And it gets at one of the issues which you're not addressing in the study at all is the limitations of the current diagnostic paradigm, because serology does not distinguish well between prior infection and current infection. So that's another unanswered question with Lyme disease. But we're happy to discuss any case, especially these strange cases. I would say we'll never have a case like this again, but we'll probably have a case like this again. So again, we're always—
I don't know, Lise, we've had, as you know, we've had 2 unusual cases.
Right, which is why Lyme is so interesting. But yes, they don't all read the textbook on classic Lyme meningitis.
Well, actually, so I can add a little. The 3-year-old I was mentioning earlier, their primary, yes, they had headache, and other symptoms. But the thing that was distressing the parents most was behavioral and mental status changes. I mean, they were describing fairly frank mental status changes, and and everyone agreed, and everyone thought, boy, this kid looks ill, and this is not right. And anyway, so it was a treatment, and there was not a great alternative explanation. Like in this case, to Katie's point, there is a potential alternative explanation. But anyway, before we move on, was there anything else about this case that tripped folks up that have a question about, or we can help with? Otherwise, I think we're done with the scenarios. Ah, okay. We do. So Ling asked, does the enrolling physician need to sign the eligibility form? And so actually in this case, for example, right, it's not the ED physician, it's not the hospitalist, it's the ID physician needs to do their assessment and say, yes, I thought this patient had Lyme meningitis. So yes, that's exactly what we did.
Or right. But I think that you know, if you as the site PI are confirming everything with the treating team, not making treatment decisions, but confirming everything, you can also be the person who signs the piece of paper confirming the eligibility as well. So if it's a tricky situation, you don't have to, you know, run to ID clinic, but it's not you as the site PI who's making the treatment decisions, but you can be the one who verifies the eligibility criteria are met.
Actually, in this case, I think we emailed the ID attending the PDF, and he remotely signed it and emailed it back. And so
there's lots of ways of doing it, but you know, having these conversations and making sure that they're eligible as per the opinion of the treating team is the key element of that. All right. So I will introduce Rachel. Are you doing the solo today, or Maxwell joining in?
Yeah, I think Max is going to join in right
Okay,
at the
perfect.
end.
So I'll just introduce Rachel and Max and Mariah, who is not part of the presentation, but helped put these slides together, going to speak a little bit from their experience over the first year and share sort of the nitty gritty of the study. So thank you, Rachel and Max.
Yeah, absolutely. So we'll just go through and kind of talk about the enrollment process. It's fairly simple. It seems, you know, it could be scary and overwhelming, but to be fair, it's honestly probably one of the easiest studies I enroll in, which is great. And there's not much to do from the, I mean, there's plenty of work to do from the RA and RC side, but straightforward, and we'll take it slow. And if you have any questions, feel free to put them in the chat, or you can email me after and we can discuss. But I think we can move to the next slide. So this is going to be a big part of a large overview of a workflow. So it's going to be cut into different areas. So we'll start with screening and consent. So the first thing you'll want to do is obviously identify an eligible patient. And to do that, you'll see some screening things on however way you watch the board in your ER or ED. If they're having the neck pain or, you know, fevers or showing signs of Lyme meningitis, you will want to grab an eligibility form and start filling that guy out. Those should be found in eRoom. I suggest, and I'll say this throughout, I suggest making sure you have all these things available prior to enrollment, so you're not, you know, scrambling for a eligibility form when you have a possible eligible patient. So obviously, you know that this can be people can be enrolled in person or remotely. This part of the process is probably the most different. The rest of it is pretty straightforward. However, so we'll start with that. You have an eligibility form. You'll start with the inclusion and exclusion. If the, oh yeah, Brenna, that was great. It's actually in Florence eBinder. So yeah, you guys just make sure you have access to that and you see everything there. So yeah, you don't get stuck. But anyway, so you'll start with the eligibility form. You'll do the inclusions and the exclusions. We'll start with the remote side. If it's happening remotely, basically you have identified that the patient is eligible. You probably see a positive Lyme test, then it's much easier to go forward with enrollment. You'll want to confirm with the physician or maybe your site PI to make sure that the patient is actually eligible prior to just, going forward. And then on the in-person side, if you see a potential eligible patient, you'll want to, if you're waiting on results, you'll want to, that's where the pre-enrollment sheet comes in. So you'll see reference or provide the pre-enrollment sheet. That's where, you see this potential eligible subject, you filled out the eligibility form as much as you can, but the positive Lyme results haven't come back yet. So at that point, you'll hand them the you'll hand them the pre-enrollment sheet, and you'll just say, when your positive tests come back, if they do, we'll be in contact. And that's when you'll switch to the remote side and kind of enroll remotely. However, if it is in person and they already are positive, they are already, this is Lyme meningitis, you can continue with the in-person enrollment. And there's not much in the difference. It's just, let's see. So whether it's in person or remote, you'll fill out the eligibility, like I said, pre-enrollment if you are still not sure if they're eligible yet, and then moving down, say that they are eligible, confirm with the doctor, inclusion and exclusion, hit them all. And then you will, if it's in person, you'll want to do the informed consent. That's going to require a signature. You'll want to go into the room, talk to the parent, let them know about the study, all the activities that they'll have to do, which we'll go into detail about. And then you'll want to hit the child assent form too. The child assent form is for kids over the ages of 8. So you'll want to get their signature as well. And then if it's remote, you'll be over the phone and you'll just basically do the verbal consent form. So there's 2 separate ones. Obviously, if it's remote, you're not going to need a signature. So that's where the verbal consent form comes in, and you'll just kind of sign off yourself that we had this conversation over the phone, they're aware, and they've consented. So yeah, and I think there's another good point. It's if you're doing it remote, we have a documentation of consent checklist. You'll see it in the second bubble to the right. It basically is just a little list, and it can make sure you hit all of the points when you are consenting. It's really useful, and I suggest using it. It's necessary for all enrollments. So make sure you have access to that, and then you can document how many contact attempts that you are doing as well. So that's kind of the first part. So like I said, eligibility form, everything else informed consent form versus verbal. So then we'll move on to the parent and participant training. This part is basically just letting the parent know of what their role is in the study. You'll start by, whether it's in person or remote, you'll want to give them copies of all the necessary documents, and I have them listed here. If it's in person, you'll do a copy, and if it's remotely, you'll just email them a version. You'll want to scan it and send it over. So it's important to get their email over the phone. So the first thing, it'll be the consent form. You'll obviously want to give them a copy so that they have it for their record. And then the assent form if the child is over 8. The next is the facial palsy photo instruction sheet. So this is for kids that are showing signs of facial palsy. If they aren't, and if you are not really sure, I would talk to the doctor. If they are, it's important for the parent to understand how to take these photos and upload them. If they are having difficulty, or I would kind of wrinkle out those things now or before when you're enrolling. But if the photos are not of good use, or they're not very good quality, we will ask them to re-upload. So it's important that they have an idea of, what we're really looking for. The next thing is the ClinCard information sheet. So that's where they're going to get their compensation. It's good when you're enrolling to kind of let them know and emphasize more surveys you do, the more compensation you'll be getting. It gives them a little bit of encouragement to continue doing these surveys, whether they forget or they just don't really want to anymore. So it's a good compensation, and that'll keep them moving forward. And as for the ClinCards, you want to make sure that their birthday and their address is accurate in red cap. We put that into our system from our end, and if it's inaccurate, it tends to slow down the process, and we'll have to get in touch with the family. So whether you hand the iPad or however you do it to the parent in the room, or you just do it verbally, I would just make sure, you know, that. Additionally, we do compensate. We usually upload about once a week. So if they're asking, you know, how I haven't gotten my money and it's Monday to Wednesday, you know, I haven't, and we usually do it a minimum of $5. So if they have filled out 3 surveys and there's only $3 on their account right at that moment, we might wait until there's $5, but that usually happens about once a week. So that's a good little note to let them know when to expect the money. And then the last thing you want to give them is the Lyme study outline of study activities for participants. This is probably the most important, which maybe not. Personally, I think it is. I think that it really lines out everything that the parent's going to be doing. It tells them about the daily surveys, the weekly surveys, the 6-week interview, and the 6-month survey. So it really allows them to stay on top. It knows what they should be expecting. And then, you know, it lets them know each survey will be compensation, like I said. So that is pretty much that. And then I mentioned the documentation of consent checklist right at the bottom. That just ensures that we hit all the points that we needed to consenting, and that you'll have to sign that off. So it's a good little checklist at the end. But I would just, you know, make a list of these items, make sure that you have them all available to you and that you're familiar with them. So if the parent has any questions on any of them, you're not kind of looking at them for the first time, but you're more kind of comfortable with answering any questions on any of the sheets. I think we can go to the next one. Awesome. So then this one is probably going to be the bulk of the work for the RAs or the RCs. So we identified eligibility. We've gotten the parents' consent, whether it's over the phone or it's in person. We've gotten the signature, like I said, the verbal. We've given them a packet of information regarding, you know, CLIN cards, facial palsy, consent, the consent, copy of the consent back. We've given them the outline of study activities. Now we're going to do REDCap. All of these things can kind of happen in this order. If there seems to be a better workflow for you and your ED, feel free to do that. But this is typically how these parts are going to go. So next, we're going to hit REDCap. Like I said, there is a good amount that you'll be filling out with the parent. So you'll see complete forms with parent. That's just going to be, you know, contact information, demographics, history of present illness, and then following the rest. Some of these are nice and quick. Contact information and demographics shouldn't take more than, you know, a minute to get that information. But some of them, you know, might take a little bit longer, for maybe 5 to 10 minutes filling them out. I would say, like I said, this is a bulk of the work that you'll be doing in person or with parents. If you are, or I guess in person, you want to let them know that this is going to take some time. This could take up to 15 to 20 minutes to go through all these forms. So if the parent is on the phone and they're like, listen, this isn't a good time, can you call me back later in the day? We want to get these forms as soon as possible and as close to enrollment as we can. So I would suggest, you know, getting another time in the day that you can do this. And then, yeah, just basically getting it as close to enrollment if you can, but make sure it's okay with the parent and they know that they're aware that it's going to take some time, because if they're in the room and they think that it's going to take 3 minutes and you're there for 20, they might not be happy. So it's a good idea to kind of let them know. And then following, you'll want to talk to the physician that was treating them. They will fill out a clinical assessment. This should be nice and quick. If the physician has any questions, I would have them maybe talk to Liz or your PI. I don't know if as an RA, I can really answer much of their questions, but at least familiarize yourself with the form. So if they do have any questions that you could answer, I definitely would take a look at that. And then the last set of forms you can answer using the EMR. So you can log into the patient's, whatever it is, whatever system you guys use at your site, and just use your chart to figure out, you know, medical history, lab results, and ECG results. All of these forms ideally will be as close to enrollment as possible. Using the EMR and might take a few days to get the lab results, or the treating physician might not answer your email for a few days. So like I said, as soon as possible is ideal. And some of these can kind of go out of order if necessary. You can, if the parent's busy, you can go run over to the physician and maybe get that report. Or if the physician is busy and so is the parent, you can kind of work on entering the lab results. So this is kind of up to you, but these are the forms that need to get done, and it really lays it out. So it should be very helpful to kind of use this in time. I think that's it for this guy. If we can go to the next. Max, if you want to hop in. I might have found my here.
All right. Well, thank you guys very much. My name is Max. I'm one of the Boston RCs here. We lost our Wi-Fi and my work computer doesn't have a functional video camera. So I appreciate your patience as I give this talk from Rachel's computer. So I'm going to be talking about the 6-month follow-up. So at 6 months, your site will receive a notification from the query manager that it's time to complete this task. And what that means is you have a 30-day window to complete the task before a query will be generated. And so this task consists of 2 parts. So the first part is a chart review in which you're going to go into the EMR, and we're looking to identify any antibiotics or steroids that were prescribed to treat the Lyme meningitis or facial palsy after enrollment. And keep in mind, RCs and RAs, that you're going to use 1 REDCap form per prescription for this. The other component of this is the healthcare utilization chart review, in which case you're also going to use the EMR, and you're going to be looking at any visits that the patient used, whether inpatient or outpatient, and you're going to want to document that as well. And like the the prescription assessment, you're going to have 1 form per visit as well. One thing that I do want to, emphasize is the only place you should be pulling this information is from the EMR itself. If you guys are having some trouble, with patients or participants not completing surveys, one of us, so Rachel or myself or another Boston RC or RA, might reach out on the phone to facilitate a follow-up. But hopefully we don't have too much of that going on. And then after the 6-month chart review is complete, the sites are going to complete the next, survey, which is like the end of the study form in the REDCap forms. Do you guys have any questions about either of those 2 tasks for the 6-month review?
Thanks. Thanks, Max. I was just going to clarify 2 things. First of all, there will be a vital status check. Brenna, do you have that coming up in your slide? So before you get to 6 months, we want to make sure you check to make sure the patient's still alive. And that's to avoid any surveys going out to families that may have their child no longer living. And again, that's very unexpected, but there will be that checkpoint, and Brenna will remind you of that. The second thing is the coordinated central follow-up is really under Tom and Nicole's awesome team, but they may also be hearing from the Boston team. So someone outside your site may reach out if we notice that they're not meeting their deadlines for the follow-up, because all the work that Rachel described is really getting them enrolled. And once they're enrolled, this is really an entirely electronic study. They're going to be getting text, hopefully, or email, text much better than email surveys. And you might not see that patient again in person during the study period. There is, of course, a qualitative interview at 6 weeks, which is not text-based, but it is virtual, not in person. And so there's a lot of work day 1, but then really it's a relatively easy study once they're enrolled. But I don't know if you want to add anything, Tom, about the centralized follow-up, but.
No, so far we haven't needed to reach out to the individual site teams for help, but in theory that could happen. That we've tried, we can't, and we don't want to lose a follow-up, so we might reach out and say, hey, do you guys mind trying, or contact the PCP or something like that, or whoever the treating physician is most likely, or will have contact with like the PCP.
As we get excited for this new season, what we did, these patients are hard to find and get in touch with, but when we do get in touch with them, they're enthusiastic about the study and very compliant with the study procedure. So that's the good the good news, our consent rates have essentially been, everyone has said yes, and our follow-up rate has been very good with very few missed study events. So, all right, next slide. Questions?
Yep, awesome. So this is just a little cheat sheet that I created for all the sites. As you can see, it's broken down from in-person to remote, and then REDCap to the far right. You can see it's saved in eBinder, and it's super helpful. So I suggest using these with your first enrollment, getting familiar before you even have an enrollment, because these will really help you walk through the process, whether that be in person or remote. And then REDCap to the right, that'll show you what steps you need to take in that as well. But basically, it's just a step-by-step. It starts with, each form, complete the eligibility, obtain that physician's signature, and then, bring that pre-enrollment sheet if you need to. In the boxes, it's a little key points or blurb to use while you're consenting. It kind of just talks about, why are we doing this? Who are we targeting? And, what are we doing? Or what would you have to do? So it talks about the daily surveys, the phone interview, weekly surveys, and all that. That little box, it really is a little helpful blurb to, use while you're enrolling. I would suggest adding more detail, but as long as you kind of hit these points and expand on those, I think that you'll get the point across and hopefully have a successful enrollment. And then following that, you will do, whether it be in person, you'll get the informed consent. And then if it's remote, you'll get the verbal consent, and then that child assent if they are over 8 years old. And then you'll see on number 4, the documentation of informed consent checklist. That's that one that I keep emphasizing, because it's really important to make sure that you're hitting all those points during the consent process. And then following, you'll provide the parent with copies of the consent, the assent, facial palsy if necessary, CLIN card information, and then the Lyme study outline of study activities. So it's really, this is just a one-page cheat sheet that you can use, that I just went over all of the different moving parts, but this should really outline it. And then the last thing is to just complete the forms in REDCap. And then if you move over to the right, you'll see the forms, complete with parent, has all the forms listed. And then with the treating physician, it has that form as well. And then with the EMR, those forms. So use this to your advantage. Please do take a look over. And if you have any questions, feel free to email me or Max or Lise or anyone on the call, and we can definitely help and, make sure that you're comfortable with enrollment. And yeah, happy to help wherever we can. I think feel free to put any questions in the chat as well. I think we have one question. Can the physician electronically sign the eligibility form? I don't see why not. I think that's maybe a Lee's question, but I think that's fine. I would say that that's okay. It's fine. What we do here is we'll even leave it in their mailbox, and we'll just shoot them an email. Like, can you, so we left something in your mailbox. Can you email it, or can you sign it? And then we'll come pick it up. If you happen to see they're on shift, we'll go run over and have them sign it. Or I think it's a great alternative to just, email it over and say, can you electronically sign this? Yeah.
Thank you so much, Rachel. I think the key element is that, the clinical team thinks they have Lyme meningitis, and that the study team, has double checked that they meet all the eligibility criteria. So that's the key part. Whether the signature is on a piece of paper or electronic is just, I think either would be accepted, right, Brenna, in terms of the documentation, but it's just the verification of eligibility by both the clinical and the research team. So however operationalized it works best.
Shannon has her hand up, so
I just had a question for what Max presented about the 6-month follow-up. Is that for patients who aren't responding at the 6-month time, or should that be done on all patients? Because I think we have a couple that would have been due in March.
It's a medical record review for all enrolled patients, whether they've responded or not. And again, what we're looking for is their treatment that they received. So using the medical record to clarify the antibiotics and the steroids that they received. And then as well as their healthcare utilization essentially related to Lyme disease from the time of enrollment to the 6-month period of time. So it's relatively brief because we're really looking for related healthcare utilization, as well as neuroimaging, any CTs, MRIs that the patient had, but that's for all patients. There's no, like, it doesn't have to be done on the 6-month day, of course, you have a window, but that would be for all patients and includes health events that occurred from the day of enrollment for the following 6 months.
There is a 6-month follow-up survey, Shannon, just like all the other surveys. They'll get automated reminders from the DCC. If they don't, then the Rhode Island team will reach out to them, and just like we talked about before, and if we can't, then we might ask your site to do it, reach out. But yeah, so there's the 6-month review that you guys do, and then there's the 6-month follow-up, which is automated. And Brenna, I don't know if you want to answer Maria's question in the chat or.
Yes, we will provide the slide presentation as well as the recording in eBinder directly after this call. So sorry, I'm writing down all of these great questions and notes so that we can provide them for everyone.
Thanks everyone for their questions.
Okay. Any other questions before we move on? All right, well, it is to me now. I'm going to go through study reminders first. So next slide. This has already been talked about, so I'm just going to briefly go through this. This study is unique because we have a centralized follow-up team. After your initial contact with the patient, you should not need to follow up with them. The site RC responsibilities are screening, consent, the baseline assessments, that 6-month medical record review that we just talked about, query resolution with inquiry manager, of course, communication with the DCC, Boston, and RAH study teams if there are any additional questions. And you may have to contact a participant if the follow-up is not successful by the other study teams. The centralized RC responsibilities, so this is the Rhode Island team and the Boston team, they coordinate all follow-up. So if a participant is not completing surveys, they will be the ones to reach out. And also if the participants have any questions about compensation or CLIN cards, you can direct that to the Boston team. Next slide. The enrollment packet. So Rachel mentioned this in her presentation. We have provided an enrollment packet. And it is broken up into 2 parts, the RC resources, which should be printed before approaching a patient, and the packet for participants, which should be printed and handed to participants if they are in the hospital or emailed if they have gone home. The RC packet includes the following forms: the workflow checklist, which that's actually not saved in the packet in eBinder because that is site specific. That's that workflow that you filled out originally and sent to the DCC. So that should be pulled from your local site folder. The eligibility worksheet, which is located in eBinder, and the documentation of informed consent checklist, which is, it also acts as a call log if you're consenting a patient remotely. And that is also located in eBinder. The packet for participants includes the pre-enrollment information sheet, again, that you'll need to pull from your local folder because it's site-specific with site-specific contact information. The facial droop information sheet. This is only for participants with facial droop. It includes a summary of facial droop, how long they will need to take photos, and how to take and upload photos. The CLIN card information sheet. It's a detailed FAQ about the CLIN card. And lastly, the outline of study activities for participants. This form details what will happen daily, weekly, at 6 weeks, and at 6 months. This is a resource for participants and parents. If time allows, please walk them through this form and make sure to ask if they have any questions. And this entire participant packet is also available in Spanish. The Spanish versions of all the forms are saved in the same location in eBinder in a folder titled Spanish Forms. Next slide. So this is just a screenshot of where this enrollment packet is in eBinder. It's in the trial master file and it's titled enrollment packet. So the first sheet on there is a table of contents that outlines exactly what is in the next two folders, the participant documents and the RC documents. Next slide. So 4 of our 14 patients enrolled have presented with facial droop. So this is just a reminder for participants who have facial droop. If time permits, please walk them through the facial droop information sheet. The sheet provides details on uploading the photos to REDCap. These are the 5 poses they will be required to take of their child weekly until resolution. If the child still has not resolved by 6 weeks, they will take photos monthly after that until 6 months. All participants who have facial droop will be required to take one final set of photos at 6 months, regardless of when the droop resolved. Next slide. Some lessons learned from year 1 photos. Note, these are my children and not actual participants in the study. They've given me permission to use their pictures, although my son was not happy with his appearance. We've had a few problematic photos, and we know that training up front can help families avoid these common pitfalls. So first picture shows no hats. That covers the forehead, which is problematic for one of the poses. Second photo, no hands holding back the hair. This can pull the forehead and distort the patterns on the forehead for the neurologist who will be reviewing these photos. Third photo, no covering, or excuse me, the hair covering the forehead or face. And then the fourth photo, no other people in the background. We don't want to capture another child that we don't have permission to be using in this study. Another thing to encourage is a neutral background. Stand against a wall or something neutral. My last photo, the one with the yellow golden star around it, is an example of how to deal with the current hairstyles that are common among teenage boys, at least my son's age. I put a lovely headband on him to pull his hair back, and then we could see all of those nice lines on his forehead that we would like to be seeing. Next slide. Okay, Clean Card. Explain to the parents and participants they will be reimbursed for their participation. They will receive a Clean Card, which is a type of debit card that Boston Children's Hospital can load money onto as study activities are completed. And Rachel already went over that, and any questions you have, you can direct those to Boston Children's Hospital. Next slide.
I'll just make one comment about the Clean Card. So we're using registered mail, which of course means that they have to, like somebody has to sign for it, which we're sort of sorting out. It worked okay in the first year, but if somebody doesn't receive the card or they feel like they haven't been reimbursed, just send us an email. We don't want any mad participants. And so we'll try to sort that out on the back end.
Okay, you also want to mention to families the 6-week qualitative interview. Explain that a research staff from Rhode Island Hospital may be contacting them at approximately 6 weeks from ED visit to talk to them about how they are feeling and how the illness affected them. Next slide. Now I'm going to outline updates that have been made to this study since the beginning. Next slide. Protocol updates. We've had 3 revisions to the protocol since study start. In version 1.06, we added the schedule of events and we updated the inclusion criteria to say clinical diagnosis of meningitis when LP not performed. Then in version 1.07, we removed that last line of the inclusion criteria to say just clinical signs of meningitis. And Lise covered that in the beginning. That was after feedback from sites as patients who may have been eligible, but that inclusion criteria was a little bit too specific. So we've broadened that. And then version 1.08, which I think Lise just notified me, it was approved yesterday. So we will be sending out all of the information for you shortly. We have updated the schedule of events to include neuroimaging report, the neuroimaging report form, and also added info on the 6-month data collection. So that's just the summary of the protocol changes that have been made since our first enrollment. Next slide. We have made extensive changes to the MOO during the off-season to add details, clarification, and more useful information for this study. Please review the MOO prior to Lyme season. Chapter 3 addresses eligibility. We added significant detail, scenarios, and information about eligibility to help you through the screening process. Next slide. In Chapter 4, we added a short paragraph about obtaining consent for Spanish-speaking patients. The process is not much different than an English-speaking patient. There are site-specific consent forms in each site's binder in eBinder. You will be required to use the approved Spanish consent documents to obtain consent for Spanish-speaking patients. The RC should work with translation services unless they are qualified to work as bilingual per the site rules and requirements. All forms will be collected in the same manner only through the services of a translator. It is important to note that RCs will need to mark Spanish as the participant's preferred language on the demographics form, and that's what I have an image of right here. This will trigger all surveys to be sent in Spanish. The demographics form is currently being updated in REDCap to allow for English and Spanish as an option. Next slide. In Chapter 5, detailed instructions were added about the neuroimaging report form. This is what the form looks like. And also the medication history was expanded to include instructions on how to enter and document medications prescribed at an outside entity. Next slide. In Chapter 6, we added additional details to the photo capturing section based on the photos we have seen so far. We also added expectations to the 6-month follow-up section. Next slide. In Chapter 7, it's been updated with detailed instructions on completing the 2 6-month forms. So I've got those circled. This is what it looks like in REDCap, the month 6 healthcare utilization chart review and the month 6 treatment chart review. Next slide. Chapter 8 was updated to include instructions on creating and saving a note to file. There is a note to file template saved in eBinder. And as always, if you have any questions on when to create a note to file, you can contact the DCC. Next slide. So lastly, these are DCC and study-wide updates, but do you have any site updates? Have you had any turnover at your site? We want to make sure all sites are ready to go as soon as they find eligible patients. If you have new team members at your site, please contact the DCC and we will send you the AD request form that must be completed by all study team members. When this form is complete, we can create the DCC account and provide access to all training material, Florence eBinder, REDCap, and Query Manager. Okay, any questions before we move on? That was a lot of study updates. Okay, we'll go to the next section. This is a brief good clinical practices refresher. The following slides have been created based on issues that have come up in the study so far and will assist us in staying GCP compliant throughout the study. So what is a source document? A source document is original documents, data, and records. For example, the EHR for medical history, the lab reports for any tests that were run, or a clinic note that documents specific study-related data that is not captured anywhere else in the chart. Is a printed REDCap worksheet or CRF an acceptable source document? Yes, if this is the first place information is recorded. For example, the demographics, or you're on the phone with mom and you collect demographic information. And if that's the case, we would just ask that you write a brief note to file to include with that study document to say that information was collected verbally from the parent. So this is the source document, and then that is an acceptable source document. So it would not be an acceptable source document if the information was obtained from the electronic medical record. For example, the RC went to the electronic medical record to obtain the demographic information. In that case, the medical record is the source. Is this clear? Are there any questions about source documents? Okay, great. We'll move on. Next slide. When is a note to file necessary and where should I save it? A note to file is a written note that describes any unusual situation during the study. A note to file documents events for other research staff or study monitors. And I would encourage you to write note to files when the unusual situation occurs, because sometimes if you're being monitored on a patient that you saw last year, you can't remember the details of that particular visit. But if there's a note to file that says, oh, this information was collected verbally from the parent, or we had to reach out to this site to collect the Lyme test, if you've already documented that, then those study details are noted and you don't have to go do a lot of past digging. Examples of a time to write a note to file. An antibiotic or steroid was prescribed outside of your study institution. During enrollment, the dose was verified over the phone with the parent. In this case, you would want to write a note to file and document what happened. The note to file becomes a supplement to the source documents. So where should I save a note to file? Note to file should be stored in the patient binder, and we also recommend you save any note to files in eBinder. All of you have a site-specific folder called Note to Files and CAPAs. So we use eBinder for monitoring. So if you've already filed those note to files right there in eBinder, they're ready to go for any future monitoring. Next slide. So just to review, the regulatory documents required for this study are first, the signed versions of the protocol signature page for each version of the protocol. So as I just outlined a few slides ago, we have had 3 revisions so far. So you should have a protocol summary page for each of those revisions since the study starts. I would recommend that each time the DCC sends out a new version of the protocol, we always include a summary of changes sheet. So print that out and the protocol signature page, which is page 3 of the protocol. Go through that summary of changes with your PI and have them sign off. Upload that document to eBinder and you will always be audit ready. Consent documents. We provide the consent documents since they are approved by the SIRB. I will always upload current consent documents to your site-specific folder in eBinder. It is your responsibility to print the approved version to consent patients on. We have seen sites and other studies print a stack of consent forms. The problem with doing this is you might enroll a patient on an old version of the consent and you may have to go back and re-consent. Always print current consent forms from eBinder. Another thing we look at is your local IRB approvals. Please upload to eBinder when you receive local approval. CVs must be updated every 3 years and medical licenses annually. The updated DOA log. If you have had staff turnover, you will need to complete a new DOA log to reflect who is doing what. Please upload logs to eBinder. Training documentation. Remember to document training of team members, especially new members, and upload documentation to eBinder. Workflow. If you update your site's workflow, please upload your updated please upload your updated workflow to eBinder. That's a tongue twister. And then lastly, PI oversight, which I'll cover on the next slide. Next slide, please. So let's talk for a minute about PI oversight. Why do I need to document PI oversight? The purpose is to prove the PI is involved in the study. If anything goes wrong, it is ultimately the PI who is responsible. So we want to make sure that you have adequately documented that the PI is actively involved in the study and what is going on. Some examples of how you can document PI oversight are, if you have a conversation about potential or enrolled patients, go make a quick note or save an email. If you go through screening questions with your PI, again, document and file. Save key emails concerning potential or enrolled patients. If you have internal meetings with your PI about patients, save meeting agendas. We document PI oversight. So we at the DCC document PI oversight with the all site call, training, and attendance logs. So when I send you those links repeatedly at the first of every meeting, that's to help you. Then we have documented that you were here at this meeting and that you've been trained. So this is what GCP entails. We want to keep the burden low on you and your research staff, but it is required for us to provide you GCP guidelines. This is a low risk study, but we want to ensure good data collection and great documentation. Next slide. Monitoring will happen for the first patient enrolled at your site, and then annually after that. We will monitor your regulatory documents and a selection of forms. Some of the things we've already learned from monitoring are to remember to complete the informed consent checklist for all patients. This is the only documentation of consent for patients that we consent over the phone. So it's extremely important for those who you're consenting remotely. Note to files are needed for any data obtained verbally without a source document. And also, primary care and other clinical records may have missing data. Be sure to look in the physician notes section and talk to your PI about where data was collected. Next slide. All right, I'm going to turn it over to Bethany Fuller, a data manager at the Data Coordinating Center, to go over a REDCap refresher. Well, before Bethany starts, sorry, Bethany, any questions on good clinical practice or study updates or anything that I just covered? Okay, it's all you, Bethany.
All right, go ahead and move to the next slide. Okay, thank you. I will take the next 15 minutes or so to go over baseline data collection. Baseline activities are broken down by case report forms that need to be collected and entered on the same day. Then there are forms that need to be collected at baseline, but do not need to be entered the same day. There are a few forms that require a chart review and one form that requires feedback from the treating clinician. So all of these can also be found in eBinder as PDF worksheets for your reference. So let's just start with the CRFs that need to be collected and entered into REDCap the same day as you obtain consent. These are very, very important to remember. So it consists of these 5 forms: contact information, demographics, pediatric Lyme meningitis symptoms measurement, history of present illness, and facial droop baseline measurement. I want to emphasize that the same day entry into REDCap is key, as the information from these forms will drive the daily and the weekly surveys. So if you do not enter one of these forms, the surveys that are sent out for the daily or the weekly, especially those daily forms that will start the very next day after enrollment, may not contain the correct information, may not contain the correct language, and it'll be missing pieces. And so these 5 forms must be completed on the same day. Other than these 5 forms, all the other baseline forms, we ask that they be entered into REDCap within the first 5 days after enrollment. So moving on to the EHR chart review, these forms should be completed based on a chart review by the research coordinators. So we have the lab results. They need to have the first and second tier results uploaded at your earliest convenience. The central study team will be reviewing the uploads to verify eligibility for the study was met. And so we're asking this to be done within the first 5 days, but the sooner it can be uploaded, the better, so that we can confirm their eligibility. The data elements for the ECG form are very straightforward. If an ECG was collected and the results were abnormal, the results should be uploaded into this form. There's also a neuroimaging form. This is to be collecting, this baseline form is to collect any neuroimaging that was performed during this baseline period. This is a repeating form. And because it's a repeating form, if there were multiple images collected, you can collect all of them. You would just repeat the form and upload 1 image per form and answer the questions. We don't expect that to happen too often, but we do want all of the imaging that's available at baseline if there is such. Also, something important to remember about this form is that we only want to collect up to the enrollment period for these. So once a patient has been enrolled in the study, we no longer want to be collecting the neuroimaging. That will be collected later at the 6-month chart review. So this is just for the baseline neuroimaging that's done. And then also for the medical history form, I just want to point out that that we are only looking at the participants' past year of medical history. We are especially interested in allergies to antibiotics, for which we may have examples listed in the MOO as well. And for the medication history form, we are interested in antibiotics and the corticosteroids taken in the last 7 days. We have specifics and examples listed in the MOO that you can reference, but know that the form asks repeating questions so that multiple medications can be entered and added in this form. So it's a little bit different than a repeating form. It will all be in the form, but after you've entered in, it'll ask, were there any other antibiotics or were there any other corticosteroids, to which you'll answer yes, and then it'll populate more fields for you to enter additional information for additional prescriptions. Also, there is one form that is missing from our slide, and this is the treatment preference form. This is not going to be part of chart review, but rather this is a baseline form that is it's completed with the participant or the parent of the participant if they're a minor. And this is to find out their experience with the Lyme treatment and how it was being discussed and decided by their treating physician. So you'll want to administer these questions to the participant or the parent as soon as possible to get their initial treatment plan responses. Are there any questions so far? I know I've been moving kind of quickly through this review. Just want to take a pause right now if there are any questions. Okay. So lastly, there is one more baseline for our clinicians to complete. This includes questions regarding the physical exam and the clinician treatment preference. So the REDCap form can be completed by the treating clinician within 24 hours of consent. So we want to make sure that their decisions and the patient is still fresh in their mind. So that's why we ask preferably same day, but within 24 hours, we would like you to get them to complete this form. And then the information should be entered into REDCap as soon as possible after completion, but no later than 5 days after enrollment, as is requested of all the baseline forms. So in summary, there are forms that are participant facing and some that are not. So a takeaway message here is to keep the data elements in mind that need to be added the same day as consent was obtained versus those that do not. And remember that it is very important for those forms to be entered the same day for our daily surveys to execute correctly for our patients. Any questions about any of our baseline forms? All right. So the last step for our sites is that after baseline, you're pretty much, it's a lot of dead space, just continue enrolling those participants until 6 months has passed. And then we do have a 6-month chart review. The RC will need to complete a medical record review at 6 months. This is broken up into 2 forms. One that's collecting their those antibiotic and corticosteroid treatments that they received after the time of enrollment up to that 6-month mark. And the other is to get more of how their life was affected, any their medical care, healthcare utilization, questions of that nature. The treatment review is a repeating form so that we can collect multiple prescriptions. And then also something to note is that because there is this 6-month gap of time, REDCap has been set up to send out an alert to remind you that this time is approaching and you'll need to review the EMRs to complete these forms.
And this slide also references what Lisa was talking about earlier, that at 5 months, you will receive a notification from REDCap about the vital status of the patient.
Right. Yes. So that's just so that if something has, in the unlikely scenario that someone of your patients has passed, that will catch that prior to those 6-month chart or any of the 6-month reminders or anything going out. Because even though you're only completing the chart review, there are some patient-facing forms that will go directly to the participant at 6 months as well for their completion. And so we would want to stop that and from being sent. Any questions? Okay, well, I think that's all that I have then. Thank you.
All right, we are going to just finish up with some final business. So the next steps for the DCC, our data managers are incorporating all Spanish surveys into REDCap. The Spanish surveys have been submitted to the SIRB as well as the protocol version 1.08. We will very soon be sending out all of these forms. We'll be uploading them to eBinder and notifying you where these forms are for your site. What this means for you is you'll need to submit the amended protocol and consent forms to your local IRB. The Spanish surveys will also be available for all IRBs that require those forms. And we will be ready to enroll Spanish-speaking patients by April 2023. Next slide.
So we'll just go back to that other slide. So we'll be sending out an email with all the details, but which includes all the Spanish forms, all the Spanish consents, and the minor updates to the protocol to version 1.08 has been approved. It's a lot of paperwork because each site has 4 versions of the consent and they're both in English and Spanish. So we're working on getting the approved versions uploaded and is into eRoom for all of you to find them. But once that's done, we will send out a group email with instructions. But just to know that you will need to submit an amendment, which has been approved by the SRB, but needs to be acknowledged by each of your sites and will allow you to use all the updated documentation.
Okay, Jonathan, is going to present this slide for us.
So I just need to make one comment regarding manuscripts. Later today or early tomorrow, I will be sending out a link via email that will be a survey intended for all site PIs. The survey is intended to gather information on PI preferences regarding authorship, participation, and manuscript writing. As soon as we have responses from site PIs, we will use those preferences to assign authorship and particularly first authorship for manuscripts. I will then be working with first authors to prepare documents that will assist our statisticians to prepare a software to create all tables, figures, and listings that will eventually be used for manuscripts. So site PIs, please look out for an email today or tomorrow with a link to a REDCap survey for authorship preferences. Thank you.
Thanks, Jonathan. Next slide. Okay, so our enrollment goal for 2023 is 80 patients. We're saying 4 to 10 patients per site, but if you can enroll more than 10 patients, keep going. We'll take as many patients as you find. Remember to contact the DCC with any new site personnel, and Lyme season is upon us. We're hoping to start seeing enrollment spike here pretty quickly. I don't know what it's like on the East Coast. We're still dealing with snow here on the West Coast. So, well, we're not the West Coast, we're the Intermountain West, but I don't know that ticks are out here in Utah yet. Lise, is there anything you want to add?
Yeah, no, we're glimmers of spring, right? Maybe some of our mid-Atlantic states are starting to see warmer weather. And again, you know, our total is 250. So the sooner we get there, the sooner we'll be done. And, you know, we had some delays in the first year, so we're really excited about this year with all sites on board. So thank you all. This retraining was really set. You know, we know we're not seeing patients now, but we may start to see them in April. We want all your sites to be up and ready to start screening and hopefully enrolling as the weather gets a little bit warmer. We appreciate all your effort between the DCC and all of our teams. We're here for questions. And these are low frequency patients, but when they come in, we really appreciate all your work to get them enrolled. And the participation, families have liked being part of the study so far with our limited experience. They have a lot of questions about Lyme meningitis. They're eager to participate in research, and they find that the study flow is pretty smooth. So we just need to find them and get them to say yes. But once we do that, things seem to be working pretty well. So reach out if we can help, and let's try to make 2023 a really high Lyme meningitis enrolling season.
Yeah, I was going to echo what Lee said. For a variety of reasons, I've wound up speaking to a fair number of the parents here at Rhode Island, mostly because a whole bunch have occurred on weekends, and we don't have a system on weekends. And I and the team was aware that it was weekend and how we're gonna contact them, follow them. We didn't want them to follow the window. And to a person, and Sarah Vargas, who's doing the qualitative interviews, has said the same thing. Super easy. The parents are really interested, really motivated, and yeah, so really excited about this coming year.
Okay, thank you,
Thanks,
everyone.
And thanks, Brenna, for really running a great training and keeping us on time. We're not over time, which is great. So thanks again for everyone's hard work.